The Radiology Review is pleased to offer the second edition of the Board Exam Study Guide, episodes 1 through 131, available for purchase as a book on Amazon or as a digital copy for Kindle. Get your copy today. Welcome to the Radiology Review podcast with your host, Dr. Matt Covington, a board-certified radiologist. For additional content, please follow the Radiology Review on social media, such as X or Instagram, at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website, theradiologyreview.com.
Welcome back to the Radiology Review podcast. On this episode, I will be discussing small bowel obstruction. As with other episodes, a free downloadable study guide will be available at theradiologyreview.com under the study guides section of the website. And while you are there, go ahead and also check out the discount code section, where I frequently have discount codes available on radiology educational resources that may be of interest to many of you. Without further ado, let's get into the questions and answers for this episode. First question: what are classic plain film findings of small bowel obstruction? On radiographs, look for distended loops of small bowel with air fluid levels. Note that small bowel loops can be identified as they have valvulae conniventes, sometimes termed plicae circulares, which are thin mucosal folds which span the entire bowel loop, whereas colonic loops have haustral folds that are thicker and do not cross the width of the colon. Small bowel loops are typically also more central in the abdomen, and colonic loops are typically more peripherally located. Next question: what are basic characteristics of a mild versus a more severe small bowel obstruction? Classic imaging findings of small bowel obstruction typically include bowel dilatation and a transition point from distended to collapsed bowel distal to the transition point. An obstructing lesion at the transition point may or may not be seen. Mild small bowel obstructions tend to be partial or incomplete, meaning bowel contents can pass beyond the site of obstruction. Vascularity will not be compromised in a mild small bowel obstruction. More severe small bowel obstructions tend to be high grade, with complete or near complete obstruction of bowel contents. These have a higher risk of vascular compromise, with associated bowel ischemia and possible bowel infarction and/or perforation. As such, one must look for evidence of pneumoperitoneum to indicate perforation, and signs of strangulation and/or bowel ischemia as signs of complication with severe bowel obstructions, including entities such as pneumatosis intestinalis. Clinically, a mild bowel obstruction may have transient abdominal pain, decreased bowel movements, and emesis. More severe small bowel obstructions may have a sudden, severe onset of pain, and in cases of vascular compromise, a rapid onset of shock. Emesis may not always be present with ischemic bowel due to acute vascular compromise, as pain may precede bowel dilatation and backup of enteric contents, which leads to vomiting. Vomiting initially is mostly of gastric contents with a small bowel obstruction, but if progresses, one would start vomiting bile and then feculent material with more severe, unresolved small bowel obstructions. Next question: what is the so-called 3-6-9 rule of the bowel? The 3-6-9 rule is a generalization of normal bowel caliber in centimeters as follows. Small bowel, less than 3 centimeters, is normal. Large bowel, less than 6 centimeters, is normal. Some add the appendix under the 6 as well, meaning that the normal appendix is less than 6 millimeters, not centimeters, and then 9 for the normal cecum being less than 9 centimeters in maximal width. Note that some advocate for slightly different measurements. such as 2.5 centimeters for the small bowel, to increase sensitivity for detection of small bowel obstruction. But the 369 rule is a general rule of thumb mnemonic that is easy to remember. Also note that this rule is not specific for small bowel obstruction, but rather bowel distension, which can result from entities like obstruction or ileus. Next question. What are imaging findings that can help distinguish between small bowel obstruction and ileus? Ileus classically shows gaseous distension of the small and large bowel diffusely, but can also be more focal, involving a so-called sentinel loop. If present, a sentinel loop is near a focal inflammatory process, such as an inflamed gallbladder or pancreas, causing short segment adynamic ileus of the adjacent small bowel. Small bowel obstruction classically shows a transition point between dilated small bowel loops proximally and collapsed small bowel loops distally, and should not have distension of the colon. Next question. What is the most common cause of a small bowel obstruction? The answer here is adhesions. The most common cause of a small bowel obstruction is adhesions, and most of these are related to prior abdominal or pelvic surgery. Note that adhesions can be occult on imaging, so in many cases, adhesions as the etiology of small bowel obstruction is made by excluding other causes. Secondary signs of adhesions include tethering of bowel non-dependently to the peritoneum, as well as abrupt angulation of an obstructed bowel loop. Next question. What are some classic causes of a closed loop bowel obstruction? Like small bowel obstructions in general, adhesions are the most common cause of a closed loop bowel obstruction as well. Other causes of a closed-loop small bowel obstruction include bowel hernias, which can be internal and sometimes very challenging to diagnose, as well as external hernias, such as an inguinal or ventral hernia, as well as with a small bowel volvulus. Next question. What are imaging features of a closed-loop small bowel obstruction? Closed-loop small bowel obstructions occur when the same bowel loop is obstructed twice at a nearby or often even the same point. A closed-loop obstruction classically presents as a dilated small bowel loop with narrowing and obstruction at two nearby or adjacent points, with a transition point proximally and another transition point distally. Dilated mesenteric vessels pointing towards the site of closed-loop obstruction transition points is sometimes present. Because the bowel loop is obstructed both proximally and distally, it has no route of potential decompression if complete, and this can be a very precarious situation for the patient. The clinical significance of a closed-loop obstruction is a higher rate of vascular compromise with associated bowel ischemia and possible bowel infarction due to strangulation of vasculature, as well as compromised perfusion due to distension causing venous compromise and congestion due to increased interluminal pressures, combined with necrosis and subsequent bowel perforation, if not resolved. CT findings supporting possible ischemia include adjacent vascular engorgement, ascites, and abnormally decreased enhancement of the affected bowel. Pneumatosis intestinalis is a sign of potentially infarcted bowel. The most classic imaging finding confirming potential closed-loop obstruction is, however, to identify two areas of occlusion among a small bowel loop. Secondary signs can include asymmetric mesenteric edema about the obstructed bowel loop, stretched or angulated mesenteric vessels, a C or U-shaped dilated bowel loop or loops, and a whorl sign from rotation of bowel loops and mesenteric vessels. That is a lot of information. Go ahead and listen to that again, or if helpful, download the free study guide and read this in written form. Next question. True or false? Roux-en-Y gastric bypass can be a cause of closed-loop bowel obstruction. The answer here is true. Roux-en-Y gastric bypass creates a rift in the mesentery, which can result in bowel obstruction, including closed-loop obstructions. Additionally, an afferent limb obstruction, that is afferent with an A, A-F-F-E-R-E-N-T, can occur after Roux-en-Y bypass, wherein the pancreaticobiliary limb is obstructed, which is closed loop because this is a blind ending loop with the remnant stomach at the other end, which does not have outflow. Clinically, this would present as a bowel obstruction with no improvement following nasogastric tube placement and attempted decompression, as the obstructed portion is the pancreaticobiliary limb and not the alimentary limb. Next question. What are potential signs of small bowel ischemia? Pneumatosis intestinalis, where air is seen in the bowel wall, as well as portal venous gas, in which intrahepatic gas is seen near the periphery of the liver, are likely the most classic imaging findings. Additionally, hemorrhage manifesting as increased attenuation of the thickened bowel wall and/or intraluminal bowel contents, or hemorrhage within the mesentery may be noted. To prevent bowel ischemia and subsequent infarction, early surgical intervention should be pursued. Of course, remember serum lactate elevation as a potential laboratory measure of ischemia. Next question. Gas seen in the bowel wall in the neonate is classic for which entity? The answer I'm looking for here is necrotizing enterocolitis. The risk of necrotizing enterocolitis is elevated in premature neonates and those with congenital heart disease or other neonatal insults. Next question. What are some potential causes of so-called benign pneumatosis? Benign pneumatosis can be caused by pulmonary disease, such as COPD, scleroderma, lupus, and other types of collagen vascular disease, various causes of intestinal inflammation, recent endoscopy procedures, GI tube placement or bowel surgery, as well as certain medications, including chemotherapy and steroids. Benign pneumatosis classically creates air-containing circumferential rings in the bowel wall and would lack additional findings suspicious for ischemia, to include an absence of bowel wall thickening, mesenteric or intraperitoneal fluid or stranding, or evidence of vascular occlusion, including abnormal, often decreased bowel wall enhancement, and no associated bowel or mesenteric hemorrhage. Clinical features are key to help differentiate benign and incidental pneumatosis, which is often clinically asymptomatic, from pneumatosis concerning for bowel ischemia, in which potentially severe patient compromise may be present. Next question. What is the small bowel feces sign? The small bowel feces sign is when one identifies the appearance of feces with air bubbles in the small bowel, whereas feces is typically only seen in the large bowel, potentially resulting from delayed small bowel intestinal transit. The small bowel feces sign, when seen with other findings of small bowel obstruction like distended bowel proximally and collapsed bowel distally, supports the diagnosis of small bowel obstruction. However, while this finding increases the likelihood of small bowel obstruction when other imaging findings of obstruction are also seen, the small bowel feces sign can also be seen in settings outside of small bowel obstruction. Note that the small bowel feces sign most commonly forms in low-grade obstructions rather than acute high-grade obstruction, is most common in the distal small bowel, and is frequently seen just proximal to the site of obstruction. Therefore, when you see the small bowel feces sign, carefully look for a nearby transition point. Next question. What are classic imaging findings of gallstone ileus? Gallstone ileus is a commonly tested concept, so make sure you are prepared to recognize this on a board exam. Gallstone ileus occurs when chronic cholecystitis creates a fistula from the chronic inflammation between the gallbladder and small bowel, allowing one or more gallstones to enter the small bowel. The gallstones can subsequently become impacted at the ileocecal valve, causing small bowel obstruction, and not ileus, the name is a misnomer. Note that gallstone ileus is rare, but is more common in the elderly. The tricky thing with gallstone ileus is they typically don't make it clear that the patient has had chronic cholecystitis, and you are expected to consider this possibility when seeing a calcified structure causing small bowel obstruction at the level of the ileocecal valve. They can test this on a radiograph or CT, showing the so-called Rigler triad, R-I-G-L-E-R, of small bowel obstruction, right lower quadrant calcification, and biliary tree gas. However, in clinical practice, most gallstones do not calcify, so one must also be on the lookout for a non-calcified gallstone about the ileocecal valve on CT when biliary gas and bowel obstruction are both present. Especially if oral contrast is given, the fistula between gallbladder and adjacent bowel may be identifiable. One final note is that Bouveret syndrome, which is B-O-U-V-E-R-E-T, is a variant of gallstone ileus in which the gallstone erodes into and obstructs the duodenal bulb. Biliary gas, duodenal obstruction, and an obstructing stone are classically seen. Next question. What are other potential causes of small bowel obstruction to consider? Besides adhesions, which is the most common cause, and gallstone ileus, which is an infrequent cause of small bowel obstruction, other causes include external and internal hernias with resultant obstruction, benign or malignant obstructing masses, small bowel volvulus, Crohn's disease with terminal ileitis causing fibrotic strictures, Crohn's and other acute inflammatory processes, and small bowel intussusception. Note that hernias causing bowel obstruction can include inguinal, umbilical, incisional, and Spigelian hernias. Internal hernias can be congenital or surgically created openings within the mesentery. Small bowel intussusception is more common in the pediatric age group as a cause of obstruction, but can also occur in adults, including with a Meckel's diverticulum or after surgery such as gastric bypass. Next question. What are classic causes of small bowel volvulus? Small bowel volvulus is more common in the pediatric age group, and midgut volvulus is classic within the first month of life, secondary to malrotation, wherein no rotation or incomplete rotation of the bowel around the superior mesenteric artery axis occurs during embryogenesis, which may lead to acute volvulus of the midgut. Small bowel volvulus in adults can be secondary to malignancy, pregnancy, adhesions within the peritoneum, or a small bowel diverticulum. Small bowel volvulus in adults can also be secondary to malignancy, pregnancy, adhesions within the peritoneum, or a small bowel diverticulum. Last and final question for this episode. What are classic imaging findings of small bowel volvulus? On radiographs, look for findings of proximal small bowel obstruction with dilated small bowel loops and air fluid levels within the proximal small bowel. Small bowel volvulus has a strong risk for small bowel ischemia. On CT, a so-called Whirl sign, W-H-I-R-L, Whirl sign, suggests volvulus of the bowel with swirling of mesenteric vessels, mesenteric edema, and swirling or twisting of obstructed small bowel loops. However, the Whirl sign can also be seen without small bowel volvulus, so this is a sensitive but not a specific sign for this entity. With midgut volvulus, one can often see the whorl sign, wherein the superior mesenteric vein and loops of small bowel are seen swirling around the superior mesenteric artery. That is a lot of information on small bowel obstruction coming your way. I hope this is helpful for many of you. Feel free to download the free study guide at theradiologyreview.com, and while you're there, take a look around at other educational resources that exist. And as always, keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.